antimicrobial resistance and novel antimicrobials for today. So until all these people who are interested so should connect, we will make a start. So thank you very much for your participation, in particular to the CDC USA, Centers for Disease Control and Prevention, and ICAP, so Columbia University, so for their support and assistance to arrange the round of these webinars. The announcement of all the forthcoming webinars and its updates is uploaded to our Facebook page of the UPHC, so where we provide announcements, and feel free to look up the previous webinars recorded in the UPHC website. And this webinar is devoted to the novel antimicrobials for treatment of the multi-resistant microorganisms. Eva Butic here with us this afternoon, clinical microbiologist. So she will be here today to talk us through more about this problem. And she is working for the University Hospital of Infectious Diseases, Zagreb, Croatia. Anyone who wanted to connect, I would like to hand over to Eva, and she will talk more about herself, and she will make her presentation. And if you have some time after that, we'll be able to take your questions. Feel free to drop it down in the chat box. And Eva, if she can afford, she will give so the floor is all yours, Eva.
Thank you for this introduction. First, I would like to welcome all of you who find the time in their schedule to listen to my presentation. As I was already introduced, I would like to say a few more words. I am a clinical microbiologist working at the University Hospital for Infectious Diseases in Zagreb, Croatia, also for many years, 15 years now or more. I'm involved in the work of a reference center for antimicrobial resistance surveillance in Croatia, and also actively involved in the work of ESMID. So it is my great pleasure to give this talk on novel antibiotics for multidrug resistant bacteria. And for a start, this is a postcard from Zagreb, upper town. So let's start with the postcard, and then we will continue with the topic. So next, these are my conflict of interests. We are all aware that antimicrobial resistance is a global threat to human health. And actually, this problem is so big that it raises so many questions. Next. And one of them is, are we really facing post-antibiotic era? Next. So in 20th century, the discovery of penicillin was sensational. Next. It was a life-saving drug given to soldiers in Second World War, and all news regarding penicillin were very sensational. Next, so nowadays we have again headlines in newspaper that are sensational, but the news are not good. Actually, we are talking about bacteria that are resistant to antibiotic that cause death in people, and in other hand, we are lacking of new antibiotics. Next, then we are really surprised that from an excellent news to bad news, it only took less than 80 years. Next, so what is the real burden of bacterial antimicrobial resistance? So this article was published last year in Lancet, and in this article, the data from 204 countries were collected on 22 pathogens for 2021 year. And in that year, analysis said that more than 1 million people die because of the infection caused with multidrug resistant bacteria. Also, these data from 2021 were compared with the data from 1990, and there was surprising news. The good news, next, was that the mortality was significantly lower, next, in the children that were 5 years old and younger. That was an excellent news. But not so good news was next that the mortality in elderly, actually next, more than 70 years old patient increased for more than 80%. And who was in charge for this increase in deaths? Next, there was bacteria, of course. Number one bacteria was Staph aureus, next. And other three bacteria were gram-negative bacteria, next. Acinetobacter baumannii, Escherichia coli, and Klebsiella pneumoniae. Next, these gram-negative bacteria are also present on WHO bacterial priority pathogen list, which is updated last year. And what this list is for? This list ranks bacterial pathogens, how urgent is the need for new antibiotics. As you can see, next, these bacteria, Acinetobacter baumannii resistant to carbapenems and Enterobacterales that are resistant to third generation of cephalosporins or carbapenems, are in urgent need for new antibiotics. They are usually next multidrug resistant bacteria. Why we think that with new antibiotics we have many challenges? Because for many years carbapenems were known as a last resort antibiotics to treat severely ill patients, mainly in intensive care units. But these age are past time because now bacteria are producing enzymes that inactivate these potent antibiotics. And with these big fives, actually, we don't have opportunity to treat infection with carbapenems. Next, but it is not only about this big five, it is about combinations. So we as a microbiologist, ID specialist, we know that bacteria can gain more than one resistance mechanism. So unfortunately, bacteria can gain more than two plasmids, and actually we are having problems if bacteria combine serine beta-lactamase with metallo-beta-lactamase. That is actually a big treatment challenge. Next, on this slide, you can see the list of new antibiotics that were approved by FDA in last 12 years. For the sake of time, I decided next to speak only on a new treatment solution for multidrug resistant gram-negative bacteria. And actually, with these new antibiotics, we have next combination with all beta-lactam plus new beta-lactamase inhibitor. In a way, new antibiotic next is cefidorocol. So let's start from the problem number one next. And the problem number one in my country, and I think also in many other countries, is carbapenem-resistant Acinetobacter baumannii. For many years, we are looking for good treatment solution because we are treating with colistin, knowing colistin-based regimen, knowing that colistin is not a good antibiotic. We are aware of its nephrotoxicity and also lower concentration in a tissue, where is the site of infection. So we have two drugs that is registered for treatment of carbapenem-resistant Acinetobacter baumannii, and that is sulbactam, durlobactam, and cefidorocol. So let's start with this sulbactam, durlobactam. Sulbactam is well-known beta-lactamase inhibitor to all of us for many decades, mainly in combination with ampicillin. But it is also known that sulbactam is not only beta-lactamase inhibitor, it is also a beta-lactamase antibiotic with activity against Acinetobacter. So in this in this combination sulbactam, durlobactam, sulbactam is active component and durlobactam is new beta-lactamase inhibitor with activity against class A, C, and D beta-lactamases. Actually, durlobactam is here to restore sulbactam susceptibility of Acinetobacter baumannii. In ATTAC trial, which I will present, we have pathogen-specific randomized controlled trial, where efficacy and safety of sulbactam durlobactam was compared to colistin, because colistin for many years was drug to treat infection caused by carbapenem-resistant Acinetobacter baumannii. In this trial, actually, only patients that had laboratory confirmed carbapenem-resistant Acinetobacter baumannii isolate were included, and in patients that had serious infection like pneumonia, bloodstream infection. A trial was done in 53 clinical sites and included 125 patients with, I will repeat, laboratory confirmed carbapenem-resistant Acinetobacter baumannii isolates. That is the reason why we call this trial pathogen-specific randomized control trial. So, primary efficacy endpoint of this trial was mortality at day 28. As you can see in red, mortality for colistin on day 28 was over 32%, while in sulbactam durlobactam it was lower, 90%. So we see that at day 28 mortality was lower. But what was surprising, that secondary efficacy endpoint, which was defined as mortality at day 14, was significantly lower for patients that were treated with sulbactam durlobactam, only 6%. Also, all other aspects of patients treated with sulbactam durlobactam were better, meaning clinical outcomes, microbiological outcomes, meaning eradication, where percentages were higher in patients treated with sulbactam durlobactam comparing to colistin. Another good news was for safety. So we know problem with nephrotoxicity in colistin, but in this study we see that a significantly lower nephrotoxicity were noted in patients that were treated with sulbactam durlobactam. Also, during this trial, 8 isolates from 125 were resistant to sulbactam durlobactam, meaning that this bacteria can also gain resistance to new antibiotic, and this resistance is mainly due to target modification, meaning PBP3 variants. Next antibiotic is cefiderocol. Cefiderocol is a new cephalosporin that use iron transport to get into cell. And this antibiotic was designed for treatment of carbapenem-resistant gram-negative bacteria and also ESBL-producing bacteria, meaning Enterobacterales, Acinetobacter, Pseudomonas, and Stenotrophomonas maltophilia. So far, we have 3 major trials that compared cefiderocol with other active drug, usually carbapenems, and I will present credible CR trial, which compared cefiderocol with the best available drug, antibiotic, for treatment of patients with bloodstream infection, HAP, VAP, and complicated UTI. So, it was a randomized controlled trial done in 95 hospitals for 2.5 years and included 150 patients. 101 patients received cefiderocol, mainly as a monotherapy, while 49 patients that were in best available therapy arm, majority of them were treated with combination therapy. Meaning combination therapy, meaning more than 2 antibiotics. So 150 patients were included in analysis, mainly patients with Acinetobacter baumannii confirmed infection, then with Klebsiella and Pseudomonas. There are different primary efficacy endpoints based on clinical diagnosis. So for patients with HAP, bloodstream infection, and sepsis, primary efficacy endpoint was clinical cure at test of cure, while for complicated UTI, it was microbiological eradication at test of cure. Also, mortality at day 28 was also analyzed. So what were the results? Overall efficacy for cefidorocol was better for all end of treatment, test of cure, follow-up, comparing to best available therapy. Also, microbiological outcomes were overall better in patients treated with cefidorocol. We also had 4 isolates that has increased MIC value for cefidorocol over 2 and 1 with over 4. But what was surprising with results of this study, results on mortality, because mortality in patients treated with cefidorocol diagnosed with nosocomial pneumonia and bloodstream infection were higher than those patients that were treated with the best available therapy. Actually, the percentage of mortality was 38 in cefidorocol arm and 29 in best available therapy arm. These results were surprising. So based on that, analysis was done on pathogen based, and it was realized that high mortality was due to Acinetobacter, meaning that those patients that had infection with Acinetobacter baumannii had higher mortality. Safety profile was good for both arms, and the results of this study concluded that cefidorocol had similar clinical and microbiological efficacy to best available therapy, and it can be considered as option for the treatment of carbapenem-resistant infection in patients with limited treated options. But also it was highlighted that in vivo activity of cefidorocol in treatment of Acinetobacter species infections was not as expected. So these results were in a way shocking. So actually post trial analysis was done, and it actually showed that that the patient treatment groups were not well balanced. So there was imbalance in patient characteristics, meaning that in cefidorocol arm there were more patients with crab infection, and there were more patients hospitalized in ICU, more patients with sepsis, septic shock, and renal dysfunction, meaning severely ill patient. And when these data were put in analysis, actually the significant difference in mortality was lost. So results in mortality were similar. Next. We are aware that cefidorocol as a new antibiotic, also we have isolates that are resistant to cefidorocol, and it is detected that it can be due to target mutation, it can be due to change in beta-lactamase, due to beta-lactamase expression, and also due to porin loss. Analysis on in vitro activity of cefidorocol was done on a huge number of isolates. Next slide. So 23 slides I'm now. So the analysis included more than 800 gram-negative bacteria. In that, it was more than 400 Enterobacterales. And all these isolates were tested for susceptibility, and MIC value for cefidorocol was determined. And results were surprising for NDM. Actually, very high MIC value for isolates that produce NDM, which actually is maybe a slight alarm that this antibiotic cefidorocol is maybe not the best solution to treat infections that are caused with bacteria producing NDM. But what else happened? Actually, we have 2 antibiotics for treating infection with crab. Next slide. We have 2 antibiotics, sulbactam, durlobactam, and we have cefidorocol. And these 3 authors asked the question, are cefiderocol or sulbactam durlobactam better than alternative best available treatment for infection caused by carbapenem-resistant Acinetobacter baumannii? Why they ask this question? Because I presented 2 studies, but actually there are very few studies that analyze new antibiotics for crab infections. One is ATTAC trial, where sulbactam durlobactam next was compared with carbapenem regimen. And we know that carbapenems are not drugs to treat carbapenem-resistant Acinetobacter baumannii. And also we have cefiderocol, where we also had colistin-based regimen, which included carbapenems, which is not a good combination. So next, with these new antibiotics, actually what we need studies that will compare best available therapy with new antibiotics. And best available therapy is actually high doses of ampicillin sulbactam. So we are lacking this data, and we need more new study to confirm the efficacy of these new antibiotics. Next slide, 25. So we still have problems with new antibiotics for carbapenem-resistant Acinetobacter baumannii infection, and we have huge number of patients affected with this bacteria. So let's see, are there any new antibiotics for crab in pipeline? Next. Last year, journal Nature came with a very good news that we have a new class of antibiotics that can be used for treatment of carbapenem-resistant Acinetobacter baumannii. Next. The name of this antibiotic is zosuраbalpin. This is a novel class of microcyclic peptide antibiotic that blocks the transport of bacterial lipopolysaccharide. Next. In vitro study analyzed MIC value, and this blue line, you can see that MIC value for zosuраbalpin are much lower comparing to colistin, especially meropenem and tigecycline. Next. Also, phase 2 placebo-controlled trial was done on healthy participants, and it was concluded that this new antibiotic next is safe and well tolerated. So we are waiting for new results and new trials on this antibiotic. Slide 29. Rifabutin is another antibiotic that has activity against carbapenem-resistant Acinetobacter baumannii, and data from this trial were presented on this year ESMID Global. And actually, we have data on mortality. As you can see, rifabutin was given with polymyxin in comparison with best available therapy, which is also colistin-based. So you can see this that mortality on day 14 and mortality on day 28 is much lower comparing mortality in patients that receive best available therapy. Next slide. Also, we have data on microbiological eradication and clinical cure, and we see that percentages are much higher in patients that receive rifabutin and polymyxin B comparing to best available therapy. Next slide. So let's back to something old and something new antibiotic. Why I said this next? Because these new drugs for treatment of multidrug resistant gram-negative bacteria are mainly combination with all beta-lactam plus new beta-lactamase inhibitor. Next slide, 34. So we have ceftazidime, which is a third-generation cephalosporin in combination with new beta-lactamase inhibitor, and that is avibactam. This combination has in vitro activity against enterobacteriales that produce MC, ESBL, KPC, OXA48. So they are not active against MBLs, but they are also active against multidrug resistant Pseudomonas. In this REPROVE study, that was randomized controlled trial, efficacy and safety of ceftazidime avibactam was compared to meropenem for the treatment of patients with HAP and VAP. Study was done in 24 countries and included almost 900 patients. Primary efficacy endpoint, the next, was mortality at day 28, while secondary endpoints were clinical cure at end of treatment, test of cure, also mortality at day 28 for macrobiological intent to treat population. Also, safety of these drugs were analyzed. Next slide. So 28-day all-cause mortality, as we can see on this slide, the criteria for non-inferiority were filled because the difference in both arms was very small. Also, for secondary endpoints, the difference was, again, very small between those two groups. Safety profile was fulfilled. So we can see that with this trial, non-inferiority criteria for the primary and secondary efficacy endpoint was fulfilled. Next. So with this slide, with this study, we concluded that ceftazidime avibactam is important new treatment option and alternative to carbapenems in patients with HAP, VAP caused by gram-negative pathogens. I can say from my own experience that when this drug was registered in Croatia and it was during COVID, actually we were very happy because we had a lot of patients with invasive infection caused by Klebsiella pneumoniae, ESBL, OXA48, which we treated with colistin-based regimen. When this drug was available in Croatia, we switched to ceftazidime avibactam treatment, and we have lower mortality because beta-lactam antibiotic are better antibiotic than colistin. Also, what about acquired, next slide, what about acquired resistance to ceftazidime avibactam? So we are aware that bacteria can gain resistance to any antibiotic, but we think that with this new antibiotic, resistance is even quicker developed. So this paper, which was published this year, actually compared 136 studies with data on susceptibility to ceftazidime avibactam in gram-negative bacteria. And as you can see here, 2 time periods were compared, and studies that were done in 2021 to 2024 actually had higher resistance rate to ceftazidime avibactam, 13%, comparing to previous time period from 2015 to 2020, where resistance was 5%. So resistance rate doubled. And mainly resistance were in gram-negative bacteria that are non-fermentative. Next. And also resistance were significantly higher in those gram-negative bacteria that already had resistance to some other antibiotic, for example, colistin, carbapenem, or they are X-drug resistant. Next. Resistance mechanism to ceftazidime avibactam is mainly due to beta-lactamase mutation, meaning mutation of enzyme, but also other resistance mechanisms are detected. But this one was mainly present. Next slide. We have imipenem, cilastatin, relebactam as a new antibiotic. I can say that this antibiotic is not so often used in my country because of epidemiological situation. So in my country, when it comes to enterobacteriales that are resistant to carbapenem, the most resistant mechanism is production of OXA48 plus ESBL. And we know next that this combination of imipenem plus relebactam is not active on OXA48. This antibiotic works on KPC, MPC, ESBL, and multidrug resistant Pseudomonas aeruginosa. So I will present data from Restore IMI2 study, which is non-inferiority trial analyzing efficacy and safety of imipenem relebactam versus piperacillin tazobactam for treatment of HAP-VAP. The study was done in 130 hospitals in 27 countries and included more than 500 patients. Majority of isolates were Klebsiella, 1/4 was Klebsiella pneumoniae, then Pseudomonas aeruginosa, 90%, and Acinetobacter baumannii, 60%. Primary endpoint was mortality at day 28, and also safety was analyzed. So these are the results of this study. So we see that mortality was lower in a group of patients that were treated with imipenem relebactam, and also clinical response was higher in patients that were receiving this new antibiotic. Also, we see that maybe some patients that were in imipenem relebactam arm had more patients with VAP and Apache score 2 or 15 or equal. And based on that, actually, we can conclude that non-inferiority criteria were fulfilled with this study. What about safety? Next slide. Serious adverse events were noticed in both treatment group, but lower in group that were treated with imipenem relebactam, and also 50 patient treatment was stopped in imipenem relebactam group, while in piperacillin tazobactam treatment was stopped in 22 patients, meaning more. So conclusion of this study was that imipenem relebactam is non-inferior to piperacillin tazobactam for treating HAP-VAP in adults for both endpoints, meaning primary and secondary, and it was well tolerated, and it can be considered as a new treatment option for HAP-VAP, especially in patients that are critically ill and that are at high risk. What about resistance to imipenem relebactam? In vitro activity of this new antibiotic was tested on more than 7,000 isolates of Enterobacterales and Pseudomonas. Isolates were collected for complicated intra-abdominal infection and urinary tract infection. And we can see that susceptibility was very, very high. Over 95% in Pseudomonas, and almost all non-protei Enterobacterales were susceptible. Next, but actually resistance were detected in some bacteria. This is a very huge collection of strains, but resistance were detected. In Enterobacterales, it was the higher number was in Serratia marcescens, meaning 18 isolates of Serratia were resistant to imipenem relebactam, and resistance mechanism was not detected. So it was not due to KPC, NDM, VIM, or GES. And also 29 Pseudomonas isolates were also resistant, mainly resistant mechanism that was not detected. Next slide. With this discovery of this antibiotic and release of this antibiotic was also revolutionary, because with this antibiotic we have in a way solved the problem with combination of different beta-lactamases. Aztreonam next. Aztreonam is well-known monobactam with activity against metallo-beta-lactamases. But aztreonam can be inactivated with class A, C, and D. In combination with avibactam, which is a new beta-lactamase inhibitor, actually aztreonam activity is restored. So this antibiotic will be active against these enzymes in Enterobacterales, Pseudomonas, and Stenotrophomonas maltophilia. Aztreonam avibactam is registered for treatment of complicated intra-abdominal infection, HAP-VAP, and complicated UTI, including pyelonephritis. Next slide. So for Aztreonam avibactam, we have results of revisit trial, and based on result of this trial, actually this drug was FDA approved. So we have a randomized controlled trial that compare efficacy and safety of Aztreonam avibactam versus meropenem plus minus colistin in treating of patients with complicated intra-abdominal infection and HAP-VAP. This randomized control trial also included patients that in whom isolates produces MBL. So at the end, we had 422 patients included in this revisit trial. Primary efficacy endpoints were clinical cure, a test of cure, and clinically available analysis set. And secondary endpoints were mortality at day 28 and microbiological eradication. So what were the results of this revisit trial? Overall results were better in Aztreonam avibactam group comparing to meropenem group. So criteria for non-inferiority were fulfilled. Secondary endpoints results were also good because we had lower mortality in patients that were treated with Aztreonam avibactam, especially if the patient had HAP-VAP. So next, so mortality in patients that were treated with Aztreonam avibactam was 10%, while in meropenem plus colistin it was almost 20%. Also, safety profile were fulfilled, meaning that Aztreonam avibactam was generally well tolerated, and only mild and moderate adverse events were notified. So the conclusion of this revisit trial is that Aztreonam avibactam is effective in treating patients with complicated intra-abdominal infection and HAP-VAP, comparing to meropenem plus minus colistin-based regimen. But what is important to highlight next is that in this trial, only 19 isolates produce carbapenemases, meaning only few with MBL producing isolates. So that is the reason why another trial was started, and that is next, Assembly trial. Assembly trial actually wanted to include only patients with MBL positive gram-negative pathogen. That is clinically relevant. And unfortunately, this trial was stopped because in a period of 2 years, it recruited only 15 patients, and 12 of them received Aztreonam avibactam. So conclusion of this study done on only 15 patients is that Aztreonam avibactam can be is a potent drug to treat serious infection caused by MBL producing gram-negative bacteria, but the data of this study actually included a small group of patients, so actually we need to be very cautious with interpretation of the results. Next. So Astronam avibactam was also a drug to treat infection caused by Stenotrophomonas maltophilia. We know that Stenotrophomonas maltophilia is a challenging isolate bacteria to treat because of a lot of intrinsic resistance. So in vitro analysis that checks susceptibility of Stenotrophomonas maltophilia to Astreonam avibactam was done and included more than 1,800 isolates. As you can see next, susceptibility was very high, almost 84% of Stenotrophomonas maltophilia isolates were susceptible to Astreonam avibactam, and the percentage was even higher comparing to cotrimoxazole, which is actually drug to treat infections with Stenotrophomonas maltophilia. So these are in vitro results of susceptibility. So actually, based on these in vitro results, we can conclude that Astreonam avibactam can be a valuable option for treatment of infection caused by Stenotrophomonas maltophilia, but further studies are needed. With this new antibiotic, we also have bacteria that are resistant. An analysis was done on these resistant strains, and resistance to Astreonam avibactam is mainly due to target site modification. Similar to cefiderocol, it is a variation in PBP3. Next slide, 51 slide. So to conclude, I choose this traffic light table, actually, where we see all new antibiotics to treat gram-negative bacteria, multidrug resistant, and we also see resistance mechanism. Green squares mean that the drug is active, red that the drug is not active. As you can see, where we lack greens is metallo-beta-lactamases. Actually, we have only one antibiotic that acts on metallo-beta-lactamase producing Enterobacterales, and that is Astreonam avibactam. Ceftazidime avibactam plus Astreonam is combination used because with these two antibiotics, we actually get Astreonam avibactam, which we want. So we have only for MBLs, we have only Astreonam avibactam, and where we still lack greens is for carbapenem resistant Acinetobacter baumannii. The green only goes to sulbactam durlobactam. As you can see, cefiderocol has yellow square because because of the data from credible trial, and also European American guidelines are not in line for cefiderocol to be a drug of choice to treat infection caused by carbapenem resistant Acinetobacter baumannii. Next slide. 52. So to conclude, I decided to present this WHO classification of antibiotics. So this is a WARE classification, meaning that all new antibiotics are in reserve group, meaning they are last resort option against multidrug resistant organism. So if you have bacteria that is susceptible to carbapenems, to cephalosporins, or to combination beta-lactam plus old beta-lactamase inhibitor, so we will use these antibiotics. So new antibiotics must be saved for treatment of multidrug resistant organism for many reasons, and one of them is because we are aware that bacteria can gain resistance to these new antibiotics, and resistance mechanism can easily spread, so we must preserve these new antibiotics. Last slide, next, for 53 slide. So when it comes to using antibiotics, we all need change. So be a butterfly and make good decisions. So if you have narrow spectrum antibiotic and it is active, then choose this antibiotic and save these new antibiotics, because we are aware that the pipeline we are lacking new antibiotics, and we are also aware that pharmaceutical companies are losing interest in research and development of new antibiotics. And with this, I would like to thank you for your attention, and I'm open for questions.
Дякуємо дуже пані Іві і
Thank you very much, Eva. Thank you very much, colleagues from ESCMID, for very laconic, for very informative presentation. Well, you have touched upon some really relevant issues, and I would really like to support your words about being smart and cautious with the use of antibiotics. Sarah, if you do not mind, we have some time for questions. Is this correct? Okay, it seems like this is quite correct. So let me check who of colleagues raised their hands. Give me just 1 second.
First, may I ask question before? Are some of these new antibiotics available in Ukraine? Because in many countries we speak about new antibiotics and some of them are not available. For example, sulbactam, durlobactam is also not available in my country.
Там чат. А де там чати? Там нас не декілька. Ось бачу чати.
It feels like Maria is trying to talk to somebody. We have ceftazidime avibactam available in Ukraine. The rest of those... Oh, we actually have Astrianam avibactam as well.
Oh, great.
Oh, sorry, we have only Astrianam. That's it. Only Astrianam.
So you have ceftazidime avibactam and you have Astrianam, but Astrianam is not a new antibiotic, so you can also have this combination of ceftazidime avibactam plus Astrianam to get Astrianam avibactam. Okay. Cefiderocol is not available.
Ми над цим працюємо, але
We are still working upon that, but at the moment it is not available.
Okay.
Так, мені
Okay.
пише пані Сара, що ми
I can see a message from Sarah that we actually cannot give the floor to our participants, to our attendees. So the approach is, if you have a question, please write your question into the chat box. Put it into the chat box, please.
В чаті не бачу питань, тільки подяки за...
I don't see questions at the moment on the chat box. I only see some good words of gratitude from everyone on behalf of the participants. Colleagues, let's give it another minute. Maybe some of our colleagues will have questions.
Питає Любов Кузнєцова.
Любов Kuznetsova is asking, what is the growth retardation area for ceftazidime avibactam?
Like activity on which bacteria, resistance mechanism, is that a question? Ceftazidime avibactam has activity against class A, D, and C. So you cannot treat MBL producing Enterobacterales. And also ceftazidime avibactam has activity against multidrug resistant Pseudomonas. I don't know if that was a question.
Можливо, уточняють зараз у чаті. Пані Любов, якщо ви нас чуєте...
Любов, if you can hear us well, please specify your question.
what is a major problem? What is the pathogen number one of this multidrug resistant bacteria in Ukraine at the moment? Is it Acinetobacter? Is it Klebsiella? Is it Pseudomonas? What is the most challenging to treat and what is the most common?
За нашими даними, найбільше
Well, based
проблем є
on our
Klebsiella
data,
pneumonia,
Klebsiella
і
pneumonia,
Acinetobacter, вона близько йде,
and it is pretty close to Acinetobacter. They're like the top two,
Klebsiella,
probably.
мабуть,
But
більше за
I
все.
would say Klebsiella is most challenging.
And which resistant mechanism?
Зараз
KPC.
уточню одну секундочку. Ігнат, який механізм резистентності?
Let me check that with Ignat. What is the mechanism for resistance, if you know?
Не можемо уточнити, тому що це більш
Sorry,
мікробіологічні
I
дані.
can't double check it right now because it is more about microbiology data and we don't have it at hand right now. So unfortunately, I cannot give you the answer right now. Sorry.
MBL, somebody wrote MBL, thank you. So that is a challenging actually. So I would like maybe to hear what is your treatment for MBLs. Thank you, MBL. I think the first question was about UCAS zone. I think UCAS has defined criteria for ceftazidimab-avibactam. As far as I know, I think that Ukrainian. I was in Kiev in 2017. We had a course to switch on UCAS, and I think that majority of laboratories are using UCAS. So you have UCAS website and also clinical breakpoints that are available. So you have breakpoint for ceftazidimab-avibactam and also for aztreonam-avibactam. For all new antibiotics, there are breakpoints.
Так, дякуємо.
Thank you very much for that.
Да, з приводу лікування синергічні тести теж ставляться.
Speaking of treatment, we can also do synergy testing. We do that, but that is like more of a prescription story, so to say.
Yes,
And the clinicians are trying to use their own data a lot.
Actually, 2 years ago, we also had this ESMID webinar for Ukraine, and we also get the question with the synergy testing. So we are aware that we can test 2 antibiotics for synergy, and it is advised to use it for ceftazidimab-avibactam and aztreonam, but actually UCAS is against that. So there is no document that will support. But if you want to give to patient ceftazidimab-avibactam in combination with aztreonam, so it is described that then you will get this drug aztreonam-avibactam, which you are actually reaching to. So synergy test, there is no official document. There are only some articles, and I know that in some laboratories it is done, but there is no document that you can refer when you interpret the results.
Пані Олена з чату задає справедливе
Miss Olena from chat is asking a very justified question. What treatment could be recommended from your side for Ukrainian situation?
But that is the reason, actually, I don't know, that is the reason why I ask what is your major problem or problem number 1, problem number 2, because with Klebsiella, even in my country, we have now Klebsiella that has ESBL, NDM, OXA48, so with 3 different plasmids. So then it is challenging. For this, we use aztreonam-avibactam. It is now available in our country. But for up to this antibiotic, we had this bypass period where we used ceftazidime, avibactam plus aztreonam, so 2 antibiotics. And previously we were treated with colistin, but we used colistin only as a last drug because we didn't have any better options. So we also, when we start with colistin, adding some other antibiotics like fosfomycin, maybe minocycline, etc., the tigecycline, so that is salvage therapy. So you are giving combination therapy with no data that support that therapy. So actually it is something that you give when you don't have anything else to give.
Так, я з вами погоджуюсь, що синергійні
I
тести,
absolutely agree.
саме як
These
ви
synergy tests,
антибіотиків,
synergy
це
testing, just like as a
така
combination
більш експериментальна
drugs,
історія,
this is
і
more like
більше
of a
терапія більш
experimental story,
називається
and it's like a last resort therapy when you see that there is no susceptibility to nothing, it is absolutely resistant, and then microbiology people and clinicians, they just have to do what they can do. And this situation is often associated with cases that come from war-associated situations, and you see those quite often. So the problem does exist.
Yes, it is. I think with this treatment of this complicated patients that are usually colonized with a lot of bacteria is to differentiate infection from colonization. That is the step number 1. So because if there are soldiers with wounds that were transferred from one hospital to another hospital, the 3rd, 5th hospital, so they are in constant contact with the healthcare, and they are colonized with different bacteria, they have open wounds, etc. So it is very important not to treat colonization. So you need to have sample that is clinically relevant and do the interpretation, meaning so not to treat results, treat the patient. So that is the important message. It's not easy in many situations, but it is very helpful as a starting point.
Так, пані Іво, я з вами повністю погоджуюсь. Дуже
Eva,
влучні
I
коментарі.
totally agree. These are very, very apt comments. And colleagues from the audience, thank you very much for your questions. If no more questions, maybe this is the due time for us to wrap up. And I would like to use this opportunity to thank Eva once again for this lovely discussion and for a very informative presentation on your behalf. Speaking of antibiotics, which we currently do not have available in Ukraine, well, we don't have it today. Maybe we may have it tomorrow. I think we will be able to get information about that soon, and we will have it at hand very soon, I hope. Some people are asking about the video, about the recording of this webinar. You can find it as usually on our YouTube channel or the website, as well as a Facebook page of the Ukrainian Public Health Center. So please visit our pages on the social networks and you will be able to see the video. Thank you very much, Eva, ICAP, CDC colleagues. It was my pleasure seeing you. All the best.
Thank you all. Am I still on?